طلبة المرحلة الخامسة، السلام عليكم ورحمة الله. نبدأ على بركة الله الفصل الدراسي الثاني ومادة Therapeutic Drug Monitoring. Therapeutic drug monitoring is concerned with the tailoring or optimization of doses according to patient needs. This means that we are going to give a specific dose for the individual according to the specification and the dimensions or the need of that patient. In addition to other references, the main two references that we are going to use throughout this course are Applied Clinical Pharmacokinetics and Clinical Pharmacokinetics Concepts and Application. Both of these references should be available in the library of our college. The topics of this course will include review of basic pharmacokinetic, review of basic pharmacodynamic, clinical pharmacokinetic equations and calculations, clinical pharmacokinetic in special population and cases, and clinical pharmacokinetic, pharmacodynamic for antibiotics, for cardiovascular agents, for anticonvulsants, and for immunosuppressants and other drugs like lithium, theophylline, anti-cancer agents, and anticoagulants. Therapeutic drug monitoring refers to individualization of dosage mainly by maintaining a plasma concentration within the target level. This target level is basically the therapeutic window. Variability between patients in drug response comes from two major sources. These are pharmacodynamic variability, which is related to drug concentration and the response, and pharmacokinetic variability, which is related to dose and the plasma concentration. This figure represents a dose-response curve. On the x-axis, you can see the log concentration of a drug in a plasma, and on the y-axis we have the percentage of individuals that have the therapeutic effect following the administration of a dose. If the dose produces therapeutic effect in 50% of the individuals, then we call this dose an ED50, which is the dose required to produce a therapeutic effect in 50% of the population. And the dose that can produce an effect in an individual might not be the same for another individual. For example, if a cardiovascular drug is given to patient A, the same dose might not produce the same effect if it has been given to patient B. This is the differences between the responses to the same dose might be due to differences in the distribution of receptors within the body. And this is obvious for some receptors like opioid receptors, beta-2 adrenergic receptors, dopamine receptors, and serotonin receptors. So this type of variability is called genetic variability in the receptor distribution. Also, there might be non-genetic pharmacodynamic variability, like the psychological factor. In practice, we might see that the administration of a placebo drug, which is a drug without therapeutic effect, without intentional therapeutic effect, and has no active ingredient. This placebo drug might produce a therapeutic effect in some individuals due to psychological response to that drug. And this is called a placebo. If the placebo drug produces therapeutic effect or beneficial effect, we call it a placebo. And sometimes we have nocebo. The nocebo drug is also a drug without active ingredients and might produce a side effect to the patient due to psychological response from the patient. So in this case, we call it nocebo drug. So we have the placebo and the nocebo drugs. Both of them have no active ingredients but can produce either therapeutic effect or side effect in the patient due to non-genetic pharmacodynamic variability, namely psychological factors in the patient. This is a typical plasma concentration time curve following the administration of a drug by oral route. So as you can see here, there is an increase in the plasma concentration with time, and we reach the Cmax, or the maximum concentration in plasma, and then there will be a decrease in the plasma concentration. The life of pharmacists or the pharmacists who work in the pharmacokinetic area will be much easier if the plasma profile of a drug could be demonstrated to be similar among patients receiving the same dose regimen. However, this is not true. For example, if we have 10 patients who were administered a 500 milligram of a drug, the plasma concentration time curve in all those patients will not be similar. There is a low chance that there will be similarity in the plasma concentration time curve following the administration of a specific or exact dose. We call this the pharmacokinetic variability. Major sources of pharmacokinetic variability could be due to compliance of the patient to the drug regimen, or due to differences in age, like in neonates, children, elderly, also due to physiological differences between patients, like in case of gender differences or the presence of pregnancy status. Also, the disease status could affect PK variability, like in cases of diseases that affect the organs of metabolism, like hepatic or renal, or diseases that affect the cardiovascular system and subsequently the blood flow to the organs, or respiratory diseases. And also drug interactions could cause PK variability. Environmental influences on drug metabolism, which includes maybe diets or the alcohol, tobacco, these would affect variability. For example, diet like high protein, low carbohydrate diet enhances metabolism. Also, genetic polymorphism of drug metabolism could produce a variability in PK parameters. Like, for example, the less effective butyryl cholinesterase enzyme, or called atypical BU-CHE, or type A, on the metabolism of the neuromuscular blocking agent succinylcholine. We have to ask a question, which is, do we need to do monitoring for all drugs? The answer is no. We do need to do monitoring for drugs in the following cases. In cases that we have marked pharmacokinetic variability or significant pharmacokinetic variability between individuals. Also in cases that the therapeutic effect and the adverse effects are directly correlated with the concentration of a drug, which means any change in the concentration in a plasma would produce a different therapeutic effect or adverse effects in the patient. Also, we do need to do monitoring for drugs with narrow therapeutic index. In these drugs, the window between the therapeutic effect and the toxic effect is very narrow, that any change in the dose would either decrease the efficacy of a drug or exceed the efficacy and reach the toxicity for that drug. Also, we should do monitoring for a defined therapeutic target concentration range, like for example in the chemotherapeutic agents, where the effective dose is very defined. So we do need to do monitoring to achieve that target concentration. Also, we do need to do monitoring in cases of desired therapeutic effect difficult to monitor. For example, in cardiovascular cases, we can measure the therapeutic effect by measuring, for example, blood pressure. While on some drugs, we cannot measure the therapeutic effect, so we do need to do monitoring to be sure that the exact dose and not the toxic dose or the subtherapeutic dose has been given to that patient. The processes of drug absorption, distribution, metabolism, and excretion are called pharmacokinetic effects. Once the drug reach the tissues and produce a pharmacological effect, these are called pharmacodynamics. According to this, pharmacokinetics can be defined as the study of the time course of drug absorption, distribution, metabolism, and excretion. Clinical pharmacokinetic, however, is the application of pharmacokinetic principles in the safe and effective therapeutic management of a drug in an individual patient. This is a plasma concentration time curve where the area of increasing in the plasma concentration is considered as the absorption phase, and the areas where the plasma concentration is decreases is represent the post-absorption and the elimination phases. Since the blood receives a drug from the site of administration and carries it to all the organs, including those in which the drug acts and those in which it's eliminated, the blood is considered as the most logical site for the measurement of drug in the body. In general, the sites to which drugs are commonly administered can be divided into two major groups. These are intravascular administration, which refers to the placement of a drug directly into the blood, either intravenously to the veins or intraarterially to the arteries. The other group is the extravascular modes of administration, which includes the intradermal, intramuscular, oral, pulmonary, subcutaneous, rectal, and sublingual routes. After extravascular administration, an additional step, namely absorption, is required for drug to reach the systemic site of measurement relative to the required after intravenous administration. In this figure, you can see the sites or the locations where we can administer the drug. So, for example, we have the lungs, which is considered as one of the sites for the drug administration. We can administer the drug directly to specific tissues or in the artery to be delivered to that tissue. Also, we can administer the drugs in the venous side to be distributed to the tissues or the systemic circulation. Also, we have the oral administration of drugs that through the gut lumen, and these are mainly the sites of drug administration. For the sampling sites, which are labeled here by the strike, we can sample drugs from the venous side. Also, we can sample drugs from the fluid excreted with kidney or urine, and also we can do sampling from the fecal excretion through the gastrointestinal tracts. So these are mainly the sites of drug administration and drug sampling. Absorption can be defined as the process by which unchanged drug, and this is important, unchanged drug proceeds from the site of administration to the site of measurement within the body, which is usually the plasma in a vein. Drug transport across physiological membranes usually occurs by two pathways. These are either transcellular transport or paracellular transport. For transcellular transport, it could be passive diffusion or passive transcellular transport, in which the driving force is the concentration differences between two sites. The drug movement usually occurs from the areas of high concentration to the areas of low concentrations. Areas of high concentration usually is the lumen, and areas of low concentration usually is the blood. And as you might remember, the diffusion through the cell membrane requires some physical chemical properties. Most important is how lipophilic is the drug to be able to pass through the membrane. For facilitated transport, it is a protein, it's a carrier mediated processes by which the drug should bind to a specific protein on the cell membrane to be transported across the cell membrane. And also this process is always specific to specific drugs, which means that the drug should be able to fit through this transporter protein to be passed through the cell membrane. For paracellular transport, this process will pass through which the drug will pass in between the cells, in between the adjacent cells. Factors influencing absorption. You might know that drugs exist in either weak electrolytes, strong electrolytes, or non-electrolytes. For weak electrolytes, it can exist in two forms. These are unionized form or undissociated form and ionized form, or we call dissociated form. The ratio of these two forms varying based on the pH of the medium. The ionized form of the drug contains a charge and it is water soluble and has very low lipid solubility, while the non-ionized form of the drug is more lipid soluble, and in most cases this low lipid solubility is sufficient for membrane permeation. The extent of ionization of a drug depends on the pKa value of the drug, which is a physicochemical property specific to each drug, and also on the pH of the medium in which the drug is dissolved. This is controlled by an equation called Henderson and Hasselbalch equation. At a pH equals to the pKa value, the drug will exist at 50% ionized form and 50% in the unionized form. As we said before, the unionized form of the drug is the form of the drug that can pass through the membranes, biological membranes. An example of this is the weak acidic drug aspirin. Aspirin in low pH, like the pH of the stomach, will be mainly in the undissociated or the unionized form, which is more lipid soluble, while and therefore the absorption of the permeation of aspirin through the biological membrane will be more favorable in the pH of the stomach than in the pH of the small intestine. While the basic drug, amphetamines, this drug is a basic drug which is in the medium of high pH, like the small intestine pH, will be mainly in the undissociated or the unionized form. As a general rule for the absorption of weak electrolytes, when the medium is same, drug can cross the membrane. This is a general rule for the absorption of the permeation, of the weak electrolyte drugs. You can see in this figure an example of some drugs with their pKa value, and you can figure out from the pKa value of a drug and also the nature of the drug, whether basic or acidic, and the pH of the media, the ratio of ionized versus unionized form of a drug. Effect of lipid solubility on passive diffusion. As we said before, when the drug has a higher lipid solubility or lipophilicity, this will enable it from passing the biological membrane. This is because biological membranes are composed mainly of phospholipid bilayer, which is a highly lipophilic component of the biological membranes or cell membrane. For a drug in case A, when the drug has a high lipid solubility, this will cause a high concentration of a drug to pass through the membrane, the phospholipid membrane, and this will make a high concentration differences between the apical side of the membrane and the basolateral side of the membrane, which is the toward the blood. And this is concentration differences will be the driving force for the movement of the drug by the mechanism of passive diffusion. So the net movement of a drug in case A, where the drug is highly lipophilic, will be from outside of the membrane to inside of the body of the cell. On the other case, or case B, where the drug has low lipid solubility, less much or a small concentration of the drug will be passed or be absorbed through the cell membrane, and this will make the concentration differences between the apical side of the membrane and the basolateral side of the membrane is very low. In result, very low concentration of the drug will pass through the biological membrane. An expression for the lipophilicity of a drug, a value or physicochemical value, we call it log P value. Through this log P value, we can measure how lipophilic is the drug. In concept, for the calculation of log P value, which is the logarithmic scale of the partition coefficient, we can calculate partition coefficient by measuring the concentration of a drug dissolved in partition solvents, which is usually an organic solvent, highly lipophilic organic solvents like octanol, and the concentration dissolved in water. We put a drug in a mixture of water and a highly lipophilic solvent, as we said before, like octanol, mix them together, leave them to separate, and then we measure the concentration of the drug that partitioned to the organic layer, and we found the differences in these concentrations. Logarithmic scale of this partition coefficient is the log P value. Here we can give you an example of how could log P value determine how the partition through or permeability through the membrane occurs. In drugs with a log P value in the range of -1 to around 2, the drug will be mainly polar compound and will have a good solubility in the aqueous media of the gastrointestinal tract, but will have poor permeability through the membrane, and the net result will be poor absorption and distribution of the drug through the system or the body. Compounds which have a log P value between 2 and 4.5, these are compounds with intermediate polarity. They would have a balance between aqueous solubility and between lipid solubility. So these drugs have good solubility in the aqueous media of the gastrointestinal tract and also have good permeation through the lipophilic biological membranes. In result, this will cause this drug to have a good absorption and distribution throughout the body. Drugs with very high lipophilicity, these are nonpolar compounds. These drugs will have a problem in the solubility in the gastrointestinal tract, despite the fact that they have a good permeation, but they will not be able to reach the apical side of the epithelial lining of the gastrointestinal tract to be able to be absorbed. As a result, this will cause a low absorption ratio of these drugs through the system. The question here, does a high lipophilicity compound have a good oral absorption? I think we have answered this question by showing the differences in log P value and the good absorption. See, here is the low lipophilicity compounds, and here is the high lipophilicity compound. As we mentioned before, the compounds with good lipophilicity and good water solubility would be the compound that would show higher absorption than the others. Other factors that could influence absorption is the blood flow to the absorption site. In passive diffusion, as we said before, the driving force for the absorption of a drug is the concentration differences between the lumen and the blood side. Once the drug is absorbed from the lumen to the blood side, blood flow will maintain the concentration differences between these two sides, as blood will act as a carrier for the transport of a drug to different parts of the system, and this will maintain concentration differences. Total surface area available for absorption is also important, and this might explain why the small intestine is the main site of drug absorption, because it has a very high surface area that is available for absorption compared with the stomach. Contact time at the absorption surface area is also important. As long as the increase in contact time with the absorption surface will permit more drug to be transported through this surface, and therefore increasing the absorption of a drug. This is a figure that shows the gastrointestinal lumen, mainly in the small intestine. This is the intestinal lumen, and this layer here, just before the apical membrane of the enterocyte, is called the unstirred water layer. Unstirred water layer. This layer will prevent the movement of highly lipophilic compounds that are present in the intestinal lumen from reaching the apical membrane of the enterocytes to be absorbed. Also, for a compound that has very low water solubility, they will not, very high water solubility, they can pass through the unstirred water layer, but then they cannot pass through the membrane because they have low permeation. Therefore, it is important for the drug to have a balance between lipophilicity and water solubility, so that it can be solubilized in the intestinal lumen, pass through the unstirred water layer, reach the apical membrane of the enterocytes to be absorbed through to the basolateral side, and then systemic circulation. Environmental differences between different parts of the gastrointestinal tract also affect absorption of a drug. An example of these differences is the difference in amount of fluid, biochemical environment, pH, microbial flora, expression of transporters, and absorption characteristics. You might see here the difference between the length of each component of the gastrointestinal tract. And more important is the surface area differences. An example here is the difference between the surface area of the stomach and surface area of all components of the small intestine, which are duodenum, jejunum, and ileum. Total surface area available in the small intestine is around or more than 200 square meter, compared with 0.2 square meter for a stomach. pH differences are also important. The pH range of a stomach is 1.8 to 2.5 according to other references. It is 1 to 3 pH range, compared with a 5 to 7.6 surface area or pH value in the small intestine. Residence time is also different. Drugs or food might spend more time in the small intestine parts compared with the stomach. The longer the residence time in the gastrointestinal part will permit more contact time with the surface area available for absorption, and therefore increases the chances of absorption for the drug. I think we have answered this question, which is why there is little absorption in the stomach for most of drugs. This can be answered due to the fact that absorption area within the available within the stomach is much less than the available absorption area within the small intestine. Also, perfusion of a drug within the small stomach is much less than the high perfusion of blood within the small intestine, which is around 1 liter per minute. Also, there is physiological differences in terms of membrane permeability. Stomach membrane or epithelial lining of the stomach has low permeability compared with the high permeability of the membranes of the small intestine. In conclusion, then the absorption of a drug from the small intestine is much higher than the absorption of a drug from the stomach. Other effects or factor that influence drug transport across biological membrane is the presence of efflux transporter. An important efflux transporter is P-glycoprotein, or called PGP. PGP is a ATP-dependent transporter that is located on the apical membrane of the cells and mainly located on the apical membrane of the enterocytes. It will be responsible for the transport of drug from inside the cell to outside of the cell. P-glycoprotein present a barrier in intestinal absorption of drugs that are specific or substrate to PGP. Most of PGP substrates are either lipophilic in nature or amphiphilic. Amphiphilic means that the drug has lipophilic and hydrophilic properties at the same time. PGP is expressed not only in the intestinal epithelium, but also can be expressed in the liver, brain, adrenal gland, and kidneys. PGP is highly expressed by some cancer cells, and it is responsible for multi-drug resistance of cancer cells. An example of the cancer cells that is resisted to the treatment of paclitaxel is the breast cancer cells. PGP also appears to work in concert or conjugation with cytochrome P450, mainly 3A4. This will be discussed later in the metabolism section of this lecture. Effect of induction of PGP on the absorption of digoxin. Digoxin is known to be a substrate of PGP. Therefore, once digoxin is absorbed on the enterocytes, PGP will act to increase efflux of digoxin from inside the cell to out of the cell, and this will cause decrease in the concentration and the absorbed fraction of digoxin. Another drug which is known to be an inducer of PGP is rifampicin. When digoxin is given alone, you can see here the black line, which is the plasma concentration time curve following oral administration of digoxin alone. You can see that the plasma concentration time curves show AUCs, or area under the curve, much higher than when digoxin is co-administered with rifampicin. Here, rifampicin is an inducer of PGP. Therefore, this will increase the fraction of digoxin that is excreted or effluxed out of the cell, and therefore decrease the fraction of digoxin that is absorbed through to the systemic circulation. An opposite of this case is the co-administration of an inhibitor of P-glycoprotein like erythromycin with digoxin. Therefore, it is contraindicated to co-administer erythromycin with digoxin because the co-administration of erythromycin will inhibit the basal activity of P-glycoprotein. Therefore, this will lead to a much higher plasma concentration time curve and the area under the curve following administration of digoxin. As you know, digoxin is one of the low therapeutic index drug, and a minimum change in the plasma concentration might hit the toxic concentration and causing a lethal effect. These are some of the transporters available in the different parts of the body and responsible for transport of drug. Here we are concerned with the PGP or multi-drug resistance 1 category of transporters. As you can see here, substrates of PGP include digoxin, fixofenadine, indinavir, vincristine, colchicine, topotecan, and paclitaxel. Inhibitors include ritonavir, cyclosporine, verapamil, erythromycin, ketoconazole, itraconazole, quinidine, and elacidar. Rifampicin is an inducer. Stephen Johnson wort is also an inducer process for the P-glycoprotein. These are also a list of transporters on the apical membrane and for the intestine and also other parts of the system. Bioavailability. The term bioavailability can be defined as the rate and extent to which an intact administered drug reaches the systemic circulation. The fraction of the dose also can be defined as the fraction of the dose which reached the systemic circulation as intact drug. For most cases, bioavailability is going to be less than 100, except for the IV administration, where the bioavailability of a drug is always 100%. To calculate the bioavailability, we have to have a reference value for the 100% bioavailable drug. This reference value is normally the IV administration of a drug, and then we can calculate or compare the area under the curve resulted from any other route other than IV and compare it with the reference value following IV administration of a drug. Therefore, an equation for the calculation of bioavailability of any drug will be AUC for the drug following administration of a drug by oral or any other route, compare it with the AUC of a drug following IV administration. And then we might be able to compensate for the differences in doses. For example, if the dose given by IV is different from the dose given by other routes or by oral route, then we should multiply the AUC of oral by the dose of IV, and then AUC of IV by the dose of oral. The total is multiplied by 100%, where the bioavailability is expressed as percentage. Some of the factors that influence the bioavailability include the sum of drug is lost within the feces and then will not pass through the wall. Some of drugs will be metabolized in the gut wall, and others that pass through the gut wall might be metabolized in the liver, and then the remaining fraction will reach the systemic circulation. Then the causes, we can summarize the causes that decrease the bioavailability after oral administration is the loss in the feces, decomposition in the lumen or metabolism of drug within the lumen itself by the action of destructive enzymes or by the presence of microbials that cause drug metabolism within the lumen. Also, destruction within the wall of the gastrointestinal tract. You might know that brush borders enzymes, or the term brush borders enzymes, refers to the presence of digestive or metabolic enzymes within the apical side of the enterocytes, which are the epithelial lining of the gastrointestinal tract. This contains, as we said, contains digestive enzymes. Therefore, drugs are subjected to metabolism by the action of brush borders enzymes within the gut wall. Also, some of drug might be lost by the action of metabolic enzymes within the liver. This effect is called hepatic first-pass metabolism. In general, first-pass metabolism, the term first-pass metabolism will include the metabolic activity or destruction of the drug within the gastrointestinal tract, and also the metabolism of drug within the liver. Hepatic first-pass metabolism only includes the hepatic or the metabolic activity of the liver. Okay, we will start with the factors that influence bioavailability of a drug. As we said before, first-pass hepatic metabolism is a major obstacle for absorption of some drugs. An example of these drugs is nitroglycerin. Nitroglycerin is known to be extensively metabolized by the hepatic enzymes. Therefore, it lost more than 90% of nitroglycerin is cleared during the first pass metabolism. These are a list of some drugs that are highly metabolized or subjected to extensive first pass metabolism. These can be memorized by knowing that nitrates, or memorizing the sentence, nitrates have large pre-systemic metabolism, and each part of these words can be transformed to the conjugated drug to be easily memorized. Nitrates for nitrates, hydrocortisones, lignocaine or lidocaine, propranolol, salbutamol, and morphine. These are examples of drugs that are extensively metabolized by hepatic first-pass metabolism. Other factor that could affect the bioavailability of drug is solubility of the drug in the gastrointestinal tract. The biopharmaceutics classification system classified drugs to 4 groups. Class 1 drugs, these drugs have high solubility and high permeability. For such drugs, these can be easily absorbed from the gastrointestinal tract. Drug class 2, which are drugs with low solubility and high permeability, and to be honest, most of new drugs are within this group. This is because the new synthesis of drugs include the addition of multifunctional chemical groups to enhance solubility, efficacy, to be more specific, to get rid of some side effect of the drug, and this will cause the high molecular weight drugs, and this will cause an increase in the lipophilicity of a drug and a decrease in the solubility of a drug. Class 3 drugs, these drugs have high solubility but low permeability. An example of these drugs include ranitidine, cimetidine, atenolol. Class 4 drugs have a problem in solubility and permeability. An example of these drugs is hydrochlorothiazide and furosemide. Chemical stability is also a factor that could influence the bioavailability of a drug. Penicillin G is known to be unstable in the low pH of the gastric of the stomach. Therefore, it will be destroyed before being able to pass through the small intestine. Insulin is also an example of a drug that is destroyed by the action of degradative enzymes available in the small intestine. Therefore, both of these drugs currently are not available by oral as oral formulations. Nature of the drug formulation could be changed in order to enhance the absorption or the bioavailability of the drug. Particle size could be decreased in order to enhance the solubilization and therefore absorption of a drug. Salt form also a property which can be done in order to enhance absorption. Crystal polymorphism is a phenomena that by which a drug could be the solubilization of a drug could be increased. Enteric coating could be used as a technique to protect drugs which are sensitive to pH of the stomach. Also excipients like the presence of binders, dispersing agent which enhance solubilization or degradation of a drug and therefore enhances absorption and bioavailability of a drug could be applied. Disposition is a term that apply to all the kinetic processes that occur to a drug subsequent to its absorption, and therefore the component of disposition include distribution of drug and elimination of a drug. Distribution, as a first part of disposition, is the process of reversible transfer of a drug to to and from the site of measurement and the peripheral tissue. The site of measurement usually is the plasma or the blood. An example is the distribution in the blood and muscle. The pathway for return of drug might not be the same as that leaving the circulation. An example is the enterohepatic circulation, which means if the drug is moved out of the plasma or out of the blood, which is the central compartment, to other peripheral compartments, it's not necessary for the drug to return to the central compartment from the same pathway. As we said, enterohepatic circulation, where the drug moved from the blood to the liver, and then some of the drug is metabolized or conjugated and excreted through the biliary tract, and then reabsorption process occurs. Also, this is a process of distribution of a drug. This is just an explanation of the enterohepatic circulation as a pathway of drug distribution throughout the system. The volume of distribution is a term that is commonly used with the drugs. It can be defined as hypothetical volume that relates drug plasma concentration to the amount of a drug in the body. And it is important to know it is a hypothetical volume. It's not a real volume. Volume of distribution in a pharmacokinetic model is used to estimate the extent of drug distribution in the body. This is an example of apparent volume of distribution for some drugs. You can see here that drugs like heparin, inulin, penicillin G, these drugs have low volume of distribution compared with the drugs that has a very high volume of distribution like amiodarone and quinacrine. These drugs, for example, quinacrine has a volume of distribution of more than or of 500 liter per kg. As we said, it is a hypothetical because it makes no sense for a body to contain more 500 liter per kg. Drugs that shows a small volume of distribution are mainly distributed within the central compartment, like heparin, warfarin, for example, both of which are drugs with low volume of distribution, and it is expected to be distributed within the central compartment. Evans blue is an example of a dye which is used to measure plasma volume because it's only distributed within the central compartment. Protein binding has a significant effect on the volume of distribution of a drug. Many drugs interact with either plasma protein or tissue proteins to form a drug-protein complex. The interaction of drugs with the proteins could be either reversible, where the interaction is temporary and the drug can be free again from being binded with the receptor, or even sometimes it could be irreversible, which means that there's covalent binding between the drug and the protein, and there is no chance for that drug to be free again. The protein bounded drugs usually form a large complex that cannot easily transfer or between the or transfer through the capillary wall, and therefore has the restricted distribution. As you can see in this figure, the free drug is only the drug that has the ability to pass through the membranes, while the bounded drug has no ability to pass through the membranes because of the formation of this large complex. So as the protein binding increases, the chances for the distribution of that drug will be decreased. And here we have a list of the common plasma proteins that are within the body. These include albumin, which is the most common plasma protein within the body. Also, we have the alpha-1 acid-glycoprotein and the small ratio of lipoproteins within the body. The effect of protein binding on the apparent volume of distribution can be summarized by knowing that displacement of drugs from plasma proteins can affect the pharmacokinetics of a drug in several ways. So this includes either directly increasing the free or the unbound drug. So directly increasing the free or the unbound drug concentration as a result of reduced binding in the blood. So the free drug will be increased. So the free drug has the ability to pass through the membranes and increase the free drug concentration that reach the receptor's site or the site of action, and this could increase the pharmacodynamic effect of the drug as more drug will reach the site of action and produce effect at the level of receptors. Also increasing the free drug concentration causing the transient increase in the volume of distribution, which means that if the amount of free drug within the plasma will be increased, then there will be high chance for this free drug to pass through the capillary membranes to the tissues, and then the volume of distribution of that drug will be increased. Also increasing the free drug concentration within the plasma results in more drug can diffuse or reach the tissues of elimination like the kidney or the liver, and therefore more of the drug will be eliminated. This is important because the plasma or the protein bounded drug cannot be eliminated or reach these elimination organs. So free drug is only the form of drug that can be metabolized or excreted within the kidney and eliminated out of the body. Here we have a list of drugs that have high plasma protein binding. These include benzodiazepines like diazepam, chlordiazepoxide, and midazolam. Also we have chloropropamide, tolubutamide, cyclosporine, fluoxetine, imipramine, verapamil, and warfarin. All of these drugs has a very high protein binding, so any displacement of these drugs from protein binding can significantly affect their pharmacodynamic effect or the pharmacokinetic effect, pharmacokinetic properties like the volume of distribution or elimination of these drugs. Elimination is an important part of the pharmacokinetic process. So elimination can be defined as the irreversible lose of a drug from the site of measurement, which is normally the plasma, and elimination occurs by either two processes. These could be either excretion out of the body, or metabolism within the body and the conversion of a drug to a different form. So excretion is the irreversible lose of chemically unchanged drug. So the same parent drug could be excreted unchanged out of the body irreversibly. And for metabolism is the conversion of one chemical substance or species to another form. Both of these processes will cause the loss of a drug from the plasma. The loss could be either by excretion of the drug out of the body, or the conversion of the drug to a chemically different compound. So the elimination of a drug from the body will normally occur through different organs. The main organ for the excretion of a drug is the kidney, through filtration and secretion, and there is a chances of reabsorption, and also for there would be a chance for drug excretion from the lungs or from by other organs like the sweating, saliva, and other organs. The main organ for drug metabolism is the liver. Also, there's a chance for drug secretion from the bile duct and then excretion of a drug through this pathway. The metabolism is not limited to the liver. There might be a chance for drug metabolism within the kidney or other organs, because, as you know, the metabolism is or the mechanism of drug metabolism is by the action of enzymes, and some of the enzymes are distributed in all parts of the body. So if a drug is metabolized by a specific enzyme that is also available in out of the liver, there is a chance for this drug to be metabolized by in that specific tissue or organ. An example for this is the metabolism of a neuromuscular junction blocking agent by the action of cholinesterases in the plasma, for example, or the metabolism of different drugs in the gut wall by the action of different enzymes within the gut wall, or even in the brain or other tissues. There is a wide range of metabolic enzymes that are distributed in all parts of the body that can act as a metabolic enzymes and then metabolize a drug. We have an important term which is drug clearance. So this drug clearance is a term that can describe the elimination of a drug from the body without identifying the mechanism of the process of elimination. So drug clearance can be defined as the fixed volume of a fluid which contains the drug that has been removed from the body per unit of time. So the total body clearance of a compound is a summation of all the clearance processes at various organs. So the total clearance we abbreviated as CLT, equals to the clearance in the renal system, which is the mainly excretion, and we have the clearance in the hepatic tissues, which is mainly metabolism, and also clearance in all other organs within the body. So the total clearance is a term that can describe the elimination or quantify the elimination of a drug in the body. So as a clearance is the rate, so it equals to the elimination rate divided by the plasma concentration. So if we change the rate, we change the expression of rate as the amount per unit of time over the plasma concentration, which is milligram per mole, and there will be milligram per minute. So the final unit of the clearance will be volume unit per volume unit per volume per unit of time, where the D is the amount of drug eliminated and the rate and d over e over change in time is the rate of elimination. So the arrangement of the above equation gives the following equation, which is the rate of elimination equals to plasma concentration multiplied by. So I think this is enough for the first lecture. We meet you inshallah in the next lecture. Thank you so much for your patience and listening.